Hi, my name is Tracy Prosen, and I'm a maternal fetal medicine specialist at the University of Minnesota. I'm also board certified in clinical genetics. And today we're going to talk about statistics, specifically as those statistics apply to screening tests. To start off with, I think it's important that we all are aware of some definitions. The difference between a screening test and a diagnostic test is important. Screening tests give us a risk assessment. They don't necessarily give us a yes or no answer. In the world of obstetrics, these are tests like MSAFP screening, multiple marker screening, and in some cases, ultrasound. Diagnostic tests, on the other hand, will give us a definitive yes or no answer to the presence or absence of a condition. And in the world of obstetrics, again, these include things like amniocentesis or chorionic villus sampling, and in some cases, ultrasound. When we talk about diagnostic tests, we talk about them in terms of their accuracy, and accuracy is generally defined in terms of sensitivity, specificity, and positive and negative predictive value. So to start out with, we'll review the screening tests and how they perform. All test results will fall into one of the four categories of a true positive, true negative, false positive, or false negative test. Of course, life would be perfect if everyone fell into a true positive or true negative test, and that is the case with diagnostic tests. But with screening tests, there will always be some false positives and false negatives. I think it's important to distinguish between screen positives and false positives. A screen positive means that we've gotten a positive test result back. A false positive means that the positive result that we got back is actually an erroneous result. So the screen positives are a combination of all of the positives, both true positives and false positives. The other point that's important to distinguish is false positives versus biologic positives. In cell-free DNA screening, because the DNA that we're analyzing from the pregnancy comes from mainly the placenta and not directly from the fetus, there can be conditions in which the fetus is not affected, but truly the pregnancy, i.e. the placenta, is. There are also other reasons why you might get a positive result with NIPT that can be explained biologically, but results in a totally normal fetus. Besides confined placental mosaicism, there may be demise of a twin early in pregnancy. The mom herself may have some sort of an aneuploidy, maybe at a mosaic level, and in rare cases, maternal malignancies may be detected. Sensitivity and specificity are characteristics commonly used to describe a test. The sensitivity is the proportion of individuals who have the condition of interest or disease that have a positive test. This is the true positives over the total number of individuals with disease. The specificity is the proportion of individuals who do not have the disease who have a negative test, so the true negatives over the total who do not have the disease. So to illustrate this, let's go back to multiple marker screening. It's been around for a long time, and commonly the risk cutoff that's used to define an abnormal test in multiple marker screening is the mid-trimester risk of a 35-year-old to have a pregnancy with Down syndrome. In the normal population, we know that 5% of individuals will screen positive, even though they don't have a pregnancy with Down syndrome. Given the risk cutoff and the sensitivity and specificity of the test, we're going to pick up around 80% of pregnancies with trisomy 21, which means we're going to miss around 20%. First trimester screening came about a few years later, and with first trimester screening, you can see that our bell-shaped curves have diverged a bit. So using the same false positive rate of 5%, our detection rate is upwards of 85%. With cell-free DNA screening, our two populations have diverged even further, but it's important to know that there is still some overlap of these curves. Positive and negative predictive value, on the other hand, are really clinically what we're more interested in. The positive predictive value is the probability that if you get a positive test, the individual has the condition. So the true positives over the total with a positive test. And the negative predictive value is the chance that if you have a negative test, that you actually don't have the disease that we're looking for. So the true negatives over the total with a negative test. Let's do a little illustration of sensitivity and specificity as applied to different populations. So what I've done here is created a generic population of 10,000 individuals and a test that has 95% sensitivity and 95% specificity, which most people would agree is a reasonably good test. I've made the prevalence of disease in this population 10%. So 1,000 out of our 10,000 individuals have the condition of interest. It's simple math to fill in the rest of the table from there based on the sensitivity and specificity of the test. So you can see with a prevalence of 10%, with a test that has 95% sensitivity and 95% specificity, the positive predictive value, that is, the chance that if you got a positive test result back, your individual is actually affected, is 68%. The negative predictive value, on the other hand, is 99%. If we apply the same test to a lower risk population where there's a prevalence of only 1%, same sensitivity, same specificity, our positive predictive value decreases down to 16%. The negative predictive value has become more robust at 99.9%, but one could question how clinically relevant that increase is. If we take it even further and we drop our prevalence to only 1 in 1,000 individuals, so only 10 out of our population of 10,000, our positive predictive value is now almost useless at 2%. The negative predictive value has become even more robust at greater than 99.9%, but again, clinically not a big change. In summary, when we're talking about the statistics of a test, sensitivity and specificity are static characteristics of a test. The positive and negative predictive values, on the other hand, are more dependent on the population that we're applying our test to. Now let's test your knowledge. Now that we've learned about these statistical principles, let's apply them to some real-life scenarios to assist us in interpreting test results. I've created a population here of 38-year-old women. So in this population, we assume a rate of Down syndrome of 1 in 129 pregnancies. In this group, we're performing multiple marker screening or mid-trimester quad screening. With a quad screen, the sensitivity would be expected to be 81%, the specificity 95.6%, and 1 in 129 translates to a prevalence of 0.775%. You can see that applying quad screening to a population of 38-year-olds, a positive test yields a positive predictive value of 12.5%. Our negative predictive value is 99.8%. If we took the same population of 38-year-olds and used first trimester screening, our positive predictive value would increase a bit to 13.5%. Our negative predictive value remains about the same at 99.9%. Now, if we take the same population but apply cell-free DNA screening, which has a sensitivity of 99.9% and a specificity of 99.8%, our positive predictive value has increased to 80%. In other words, 80% of individuals who get an abnormal result actually have an affected pregnancy. The negative predictive value is extremely robust at 99.999%. If we take those same cell-free DNA tests and apply it to a population of 28-year-olds, in a 28-year-old population, the Down syndrome rate is 1 in 855 pregnancies. The same sensitivity and specificity, just a change in prevalence, takes our positive predictive value down to 38%. Again, that means that 38% of individuals who get an abnormal test actually have an affected pregnancy. If we used a multiple marker screen in this same population, our positive predictive value is only 1.94%, and with a first trimester screen, our positive predictive value is only 2.09%. Let's say that we've got two patients. One is 45 years old. The other is 35 years old. The a priori risks in those two pregnancies are quite different, although they're both in the high risk range. Because the a priori risks are vastly different in the two populations, the positive predictive values for cell-free DNA screening are going to be very different in the 45-year-old versus the 35-year-old. In either case, if a positive result were obtained, it would need to be followed up with an amniocentesis. Now that we've discussed sensitivities, specificities, positive and negative predictive values, these tools are definitely important in helping your patient decide which screening test or diagnostic test might be best for her and her family. There are certainly other considerations as well, including financial factors, pregnancy timing factors, turnaround for test results that also will come into play. But let's say that we've got a patient who has decided which test is best for her, and we now have those test results to deal with. If we've got a high-risk patient, that is, let's say someone who is 38 years old, who had screening done with cell-free DNA early in her pregnancy prior to having any other screening information, such as a first trimester screen or even an ultrasound, and we have an abnormal result in hand, we need to know what to do for the next step in her evaluation. Certainly, I would start with an ultrasound to make sure that there is or isn't anything going on with the pregnancy that might give us more information as to how to interpret that test. If we've got a patient who had an abnormal screen and we do an ultrasound and we see a very normal looking fetus, we need to take that into consideration in interpreting those results. I certainly wouldn't encourage that patient to make any decisions based on cell-free DNA screening alone, and would offer a diagnostic test, either a CVS or an amniocentesis, depending on what the timing was in the pregnancy. If, on the other hand, we have an abnormal test result back in that advanced maternal age patient, and we do an ultrasound, and we see several sonographic features consistent with Down syndrome, this is just one more piece of information. again, I would not encourage the patient to make any decisions about the pregnancy based on that information alone, and would offer a diagnostic test. But it would certainly be a different conversation to have both sonographic features of Down syndrome and a cell-free DNA screen that give us an abnormal result. Let's talk about some more unusual circumstances. What if we had a patient who is 35 years old and had a cell-free DNA screening that came back positive for trisomy 18? She has a mid-trimester ultrasound which shows a very normally developing pregnancy, but in the first trimester, a twin pregnancy was noted with loss of a co-twin at 7 or 8 weeks gestation. One of the things that needs to be considered is, are the trisomy 18 cells coming from the fetus that we're looking at in the mid-trimester, or could they be coming from another source, such as the demised twin? Because cell-free DNA screening is derived mainly from cells from the placenta, it's very plausible that the abnormality came from not the fetus that we're seeing in the mid-trimester, but the twin demise. This is a scenario where follow-up with diagnostic testing in the form of an amniocentesis would be critical. Another unusual circumstance would be a screen positive for monosomy X in an older mom. Cell-free DNA screening is a test that's typically applied to an older, at-risk population. But monosomy X is actually a condition that is not related to maternal age. In fact, the risk for monosomy X doesn't change with maternal age at all. In the absence of sonographic findings suggestive of Turner syndrome, such as a cystic hygroma, a cell-free DNA result suggesting monosomy X in a woman of advanced maternal age may actually be due to mosaicism for monosomy X in the mother herself, as women tend to lose one of their X chromosomes in a small proportion of lymphocytes as they age. Now let's test your knowledge. So now let's talk a little bit about the next evolution of cell-free DNA screening, that is the addition of microdeletion testing. Microdeletions, unlike the common aneuploidies, are not related to maternal age, and so there is a relatively rare subset of patients that would be at an increased risk for these conditions. Certainly, if we have a pregnancy that we feel is at an increased risk for one of these microdeletions, such as a pregnancy with a conotruncal heart defect, those pregnancies would be at a higher risk than the general population. So what if we had a patient who we had a cell-free DNA screen that was obtained because the fetus had a heart defect? We've got the test results back for the aneuploidies, and trisomy 21, trisomy 18, and trisomy 13 testing was all negative. But the test for deletion 22 was positive. Because this is a fetus that has a characteristic of the DeGeorge syndrome, the positive predictive value in that particular pregnancy is reasonably high at around 90%. If, however, we did a cell-free DNA screen on a lower risk patient, that is one who had abnormalities on ultrasound, but none that were suggestive of deletion 22q, and got a hit on the 22q deletion, the positive predictive value in that case, without features suggesting DeGeorge syndrome, would be around 10%. Now let's test your knowledge. Now that we've interpreted results, let's look further into some ways that data may be presented in ways that can be misleading or misperceived. In most NIPT studies, the positive predictive values were obtained originally in a high-risk population. It's inaccurate to apply those same positive predictive values to a low-risk population because, again, the prevalence of disease in those populations is vastly different. Results of testing are reported differently by different companies. Some companies report a positive or negative result, while others choose to report a risk ratio. It's important to remember that risk ratios are not necessarily directly interpretable as a risk to the patient. For example, if a risk of greater than 99% for Down syndrome is reported, that does not mean that that pregnancy has a greater than 99% chance for Down syndrome. When a test is reported to be 99.9% accurate, that would mean that 99.9% of the time an individual is getting the test result that's correct for them. This should not be confused with the sensitivity or the positive predictive value. When comparing one NIPT test to another and the sensitivity and specificity and positive and negative predictive values for that particular test, it's important to know what the test population was and how the statistics were applied to the population. For example, if there was a test that had a large failure rate in the population, were the individuals who had failed NIPT testing included or not included in the sensitivity and specificity statistics? In some studies, failed samples account for nearly 10% of all samples. And within those failed samples, the rates of aneuploidy have been as high as 20%. As we've mentioned, the 22q deletion is one that is a relatively low risk in the general population. It's further confounded by the fact that 85% of individuals that have the deletion have a typical 3 megabase deletion that would be detectable by NIPT. Unfortunately, 15% of individuals have a deletion of a size below the threshold for NIPT testing. So when the sensitivity and specificity for detection of the 22q deletion is reported, it's important to know, were these detection rates for a population who have a deletion of any size or only for those who have a deletion above the threshold for testing? Prader-Willi and Angelman syndrome are another example of testing that can be quite confusing. Because Prader-Willi and Angelman syndromes can be due to a deletion or can be due to uniparental disomy or methylation abnormalities, detection rates for these conditions can be quite misleading. Getting back negative testing would only detect those cases in which a deletion is the cause for the condition. Deletion testing will not detect those cases caused by uniparental disomy or by methylation abnormalities. In summary, a good understanding of these statistical principles is critical in your ability to both help your patient decide which testing strategy might be best for her and her family, as well as helping them to interpret the results of the testing that's been obtained. Now let's test your knowledge.